on diseases as possible, then you can really concentrate wealth within your company. And we've seen I think historically an unprecedented concentration of wealth in the last 2 years. But that's, again, a continuation of what's been happening in Western society over a few decades.
For many of us, the pandemic was the first time we became aware of a global public health apparatus and the role of institutions such as the World Health Organization and their role in global health governance. Over the past 2 years, we've seen for the first time how such intergovernmental organizations and NGOs can influence our governments in times of crisis. In this episode, we're going to dig deeper to find out the role of global planning for health, be it for pandemics or general health, and whether global public health planning is the only way forward, and what are some of the lesser known influences on the World Health Organization today that are shaping the future of global health governance of tomorrow. I'm joined to unpack this conversation today by David Bell, who is a clinical and public health physician with a PhD in population health and a background in internal medicine, modeling, and epidemiology of infectious disease. Previously, he was the director of the Global Health Technologies at Intellectual Ventures Global Good Fund in the USA, program head for malaria and acute febrile disease in FIND in Geneva, and coordinated malaria diagnostics strategies with the World Health Organization. He's a man with great experience when it comes to public health, and he maintains that accurate data and balanced evidence should be made available to public and key decision makers in order to make decisions that are in everyone's best interests. He's a board member of Panda and leads the socio-political projects on global public health. I'm delighted to be joined by David today for this fascinating exploration into global health governance. And we'll also be talking about the Pandemic Preparedness Treaty and its role in what I've just outlined. David, welcome to the Elevate podcast.
Thanks, Dan. Thanks for inviting me.
So, David, to kind of kick us off, I'd be really interested to know what led you to start your work with Panda. Our audience are likely to be familiar with Panda, taking a critical examination of the pandemic management over the last couple of years. What led you to seeking an outlet to examine these issues in such a way?
Yeah, thanks. So I think, like quite a few people who are working in public health, I hope so anyway, very early on in about February 2020, certainly by mid-March, it was becoming clear that something was wrong in the response to COVID. It was clear by then and published in March that there was a very strong bias in mortality towards very old age. It was becoming clear that there were comorbidities that were involved that made it much more likely to die. And conversely, that most people, including young adults and children, working age adults, were at very, very low risk, especially if they were fit. So that was clear in March 2020. And it's also clear, it's standard orthodox public health, that if you make people unemployed, reduce their income, reduce their ability to make their own decisions, so reduce social capital. This is standard public health. It reduces it reduces life expectancy, increases all-cause mortality. So we know that shutting down society will do harm. In any public health response, you're always weighing up the risks and the benefits of what you're doing. We suddenly went into lockdowns, which was a new term in public health. It's never been done before. And it's actually in late 2019 that WHO published their pandemic guidelines, which advised against border closures and work closures, etc., except in extreme conditions, which is clear when most people dying are over 75 and it's very few in real terms are dying. It's not an extreme situation. So we were going against orthodox public health in the response, but this wasn't being talked about. So, like I think probably quite a lot of others, I started writing to journals and writing to papers and so on, thinking this is so obvious. If you stop cancer screening, more people will die of cancer. Otherwise, we wouldn't do cancer screening. Yeah. So, if you stop people going to the local clinic with some chest pain, they're more likely to die of heart attacks because they'll be picked up too late. That's why we have local clinics. So when we stopped all this, it was obvious that we were going to kill a lot of people. And it was becoming obvious that there weren't that many people who were going to die from COVID. And it was very much a one age group, a well-defined subset of the population, and you could concentrate all your efforts on them and in the meantime have everyone else living normal lives, paying taxes, supporting the services that you're giving to these vulnerable people. So that wasn't happening. It was the opposite response, where we just universally locked down everyone. Except some people who seemed to be very wealthy and were busy flying around the world, apparently encouraging this response. So this all seemed wrong. So I, like others, wrote to newspapers, wrote to journals, and found everything's rejected. Yet they were publishing things like, we were in for a catastrophe. The New York Times every day would have on the front page, this many people died. It wouldn't say, half of these people were over 83 and 90% of them had serious illnesses which would have killed them in the next few months to year. It just said X number of people died. And we'd never seen this before, day after day. So something weird was going on there. And there was no context, and public health is all about context. So I was trying to figure out, how do you get some word out, I guess. And I did see one article, an early one from South Africa, in one of the local newspapers there, which it was an analysis of about 30 countries that showed that lockdowns didn't seem to be having any impact on viral transmission, which isn't surprising. And 2 weeks to flatten the curve made sense. And I was writing a couple of articles on LinkedIn early on that, if we thought this was really bad back in February, maybe we lock down for a couple of weeks while we get the ICUs ready. But then, you knew that if it went on more than a couple of weeks, mortality would, from other diseases in the long term, would start to overtake any lives you were going to save. Because a respiratory virus spread, they usually spread by aerosols. This one is, as we discovered, but it's not surprising. You don't stop them by confining people in their houses, stopping them from earning a living, and closing all the windows and making them less fit and fatter, etc. I mean, these are immune competence is important in respiratory diseases. There's a lot of things, including just how happy you're feeling, how least stressed you are, etc., which improve immune confidence. So scaring people, confining them in close quarters together, not letting them earn a living is not, a good long-term strategy. I think I got on Twitter on advice of a journalist friend, because I was trying to find information, trying to say things, I guess.
Yes.
So I'm not a social media person, so I've never been on Twitter before, and I was always a bit dismissive of it. But there were some people there, such as Ivor Cummings and so on, who were and Alex Berenson at the time were posting data from human health and services websites, etc., hospital websites. So it was real data, and they were just making it available so that you don't have to try to find it yourself on the internet. And this data was just backing what my gut feeling told me, that this was not making any sense. But these people were all getting denigrated, and Alex Berenson disappeared from Twitter, like many, essentially for telling the truth or a reasonable analysis of the truth. I found Panda. I think I saw podcast with Nick Hudson and Ivor Cummins, which alerted me to their existence in South Africa. But so Panda is, just to explain, it's pandemic data and analytics. It was started in South Africa, but it's a global organization, a few hundred members from all sorts of, it has various sort of data scientists, public health people, economists, political scientists, etc. And a lot of others, basically people who are interested in what is going on. The aim of Panda is not to push any particular agenda. It's to try. I think what we can all see in common is that there is a loss of rigorousness in public health, and it seems to be a bias in where things are going, and evidence isn't counting for much anymore. So the underlying aim of Panda is to try to emphasize evidence-open discussion in science and public health, and more broadly, I think, in society.
That's a really useful context. And I suppose within that context, David, it's useful to understand what your perceptions are around what some of the changes have been within global health governance, and even as far as the kind of humanitarian efforts over the last couple of years. What are some of the specific concerns that have stood out for you the most?
Yeah, so most of my public health work has been in low middle income country health, which is now called global health. So it actually goes back more than 2 years. So 20 years ago, 25 years ago, this area was sort of called tropical health, and it was a bit of a niche. And there's at the London School and a bit at Harvard and a few other places that did tropical health, Mahidol in Thailand, etc. But it was a niche area with a few people and tiny funding, and countries had, countries the size of Tanzania would have $40,000 budgets for malaria, those sorts of things, and they'd work out of a tin shed. So it was a really neglected area. A lot of people die in low middle income countries because of poor public health. So a lot of money started coming in around the year 2000 or so, including a lot of private, as we call philanthropic money. And the Global Fund started, which is a facility like a international grant agency for giving money to countries for the three main diseases of their concern: malaria, tuberculosis, HIV. So there's a huge influx of money. Countries started, they went from $40,000 budgets to $10 million budgets for malaria within a year, which was really interesting. How do you use that money when you're not used to it? But clearly there was a need for more money. All this was seen as a good thing. Public-private partnerships started arising where the private sector would work with the public to increase the amount of money available and even directly implement programs, etc. And again, it seemed a good thing because lots of people die of preventable diseases, and lack of resource is a big part of that. So there is a steady increase in money from private sources in particular, but then inevitably, I think with this came an increase in influence of those private sources. And you can understand that if you're giving a truckload of money for a particular disease, you want to see that used the way that you think is most effective. So you will direct it to try to avoid wasting it. The problem is that you as an individual may be from a country that doesn't even have those diseases, that you have no background in the sort of human behavioral issues, the cultural issues around those diseases, and you're one brain versus billions. So you actually can't know necessarily the best way to do things. You just think you do, because we all think that way. There's also an underlying problem that you end up, democracy is a thing that is important, and human freedom to choose is important, but as you start concentrating decision-making within individuals, and especially individuals who don't understand the problem very well, then you end up taking away the freedom of other people to choose. So we've seen this increasing influence of individuals and corporations as they give more money. And the WHO budget, so the WHO is about $3.5 billion a year budget. Traditionally, it was, when the WHO started in late 1940s, it was nearly all core money. So countries would give money, the WHO would use it as they thought best. Now, most of the budget, both from private and from countries, is they're called voluntary contributions, and it's directed. So you will say, we will give you this money, you use it for malaria. Or in the case of private individuals, we will give you this money, you will use it for this malaria program, you will hire these people, and you will do this work over this time span. So essentially the WHO is starting to be used by countries as a vehicle for and by individuals as a vehicle for what they want to do, which is not necessarily what, the people in the 40 odd countries in sub-Saharan Africa might want or need. So there's been this shift. There's been an increase in money, but there's been this shift away from the sort of core public health, community-oriented approach of communities a resource to make their own decisions on health, to a very vertical, centralized, directed model. And this model it then becomes commodity-based, because we know if we go back to public health in wealthy countries, 150 years ago in Europe or the US, mortality was pretty similar to sub-Saharan Africa now. And people died on average at about 35, 40 years of age. That was because a lot of them died in early childhood, and that averages, pulls the average down. Most of that improvement came through improved living standards, improved nutrition, removal of really abusive work practices, and better air, better water. So, and then we added antibiotics, which had a huge impact. Very late in the game, apart from say smallpox, very late in the game we added vaccines, which improve things a bit further. But if you look at the graphs of life expectancy, the vast majority of the improvement came before vaccines. Antibiotics had a bit, but most of it is just better living conditions. And that's what public health is. And we know from sub-Saharan African countries that if you improve the clinic, you fix the toilet, you make it an attractive place to come, so that people will come early when they're sick, they'll be seen very early, and the clinic is supplied with basic commodities, basic antibiotics, basic diagnostics, etc., then you will address most of the addressable mortality just by doing that. And then, you add for the vaccines and so on. And vaccines, certainly some like measles, are quite important in these countries for reducing mortality. But overall, it is having better health workers, having better access to basic health care, and having better economies and living conditions. So when you start having very heavy corporate influence and private influence, and even countries directing their funding rather than just giving core money, they need to see something for it. And you can say, we vaccinated 50 million kids and therefore we saved X number of lives. That gets in the papers, it gets on the BBC. But if you say we trained 20,000 health workers and now they're probably seeing more people, and over the next 10 years, we're going to see much lower mortality, probably in kids and so on. It's important. It actually has more impact, perhaps, but it's not going to excite anyone. It's not going to excite the taxpayers. It's not going to excite the individuals who want to give money and want some positive feedback from them giving money. So essentially, it's a long way of saying we've seen the sort of loss of this horizontal community-based approach, and we've seen a very centralized approach, which is driven by private, very much in corporate money, And not just through WHO, but we've seen a rise of other organizations, Gavi, which manages vaccine, Unitaid, which is there to promote commodities, so diagnostics, vaccines, antibiotics, their use in bed nets, etc., in low-income countries. And more recently, CEPI, which is an organization purely based on pandemics and mostly on vaccines for pandemics. So these organizations have arisen whose whole reason for existence is just supplying and promoting commodities, in the last case, just for pandemics. So they're parallel now to the WHO. And if they don't run this sort of vertical approach to public health, then they haven't got a reason for existence. If they're not pushing commodities, there's not a reason for existence. So we've created a system in public health, in global health, where a large part of the workforce is dependent on supplying commodities and a commodity-based approach to health, rather than a basic access and improved living condition approach to health. So you need both, but we know that improving living conditions is the key to get everything else done. And that's gone on the back burner, and it's commodities and buying stuff, which is at the top. So in that context, we saw with the pandemic, with COVID rather, that the emphasis was almost immediately on, we need a vaccine to fix this problem. And we will vaccinate everyone, as it turned out, irrespective of risk and irrespective of immunity. So, it's extreme now, but it's a continuation of what has happened over the last 20 years, which to me is sort of commoditization, vertical approach to public health, and a loss of concern of conflict of interest. So, the public health gurus now in the newspapers are the CEOs of pharma companies and the big investors in pharma companies. 10 years ago, that would have been sort of anathema. The papers would have been pointing out this person's just made tens of billions of dollars. And they're promoting exactly the same response, which didn't seem to have a big impact, but will make them tens of billions of more dollars. Therefore, maybe we should get another voice as an alternative. But that's not happening now. We just focused on these very high-profile corporate-based or private-based individuals who don't necessarily have a training in global health, but who, because of wealth and because of the way that money is going into health, have essentially not bought but acquired this huge influence.
Yes. So, what I'm hearing is what you witnessed in the kind of developing countries, if you will, the centralization of health management, the corporatization of that, the commodification through pharmaceuticals and other interventions, has created the conditions where outside influences have more influence over a perhaps more holistic approach to healthcare, which encompasses a range of viewpoints and a range of assessments when it comes to the overall management of public health.
And which would encompass pharmaceuticals and vaccines, but which they're tools within a much larger context, and we've sort of lost that. We think that they're health. Yeah.
I mean, it seems that the pharmaceutical route itself, which happens to be the most profitable aspect of public health, has risen in dominance in a way that, well, as we've witnessed over the last couple of years, it's an untouchable force that it can't even be questioned or critiqued by any public and public health officials alike. But it feels to me, for what you've described, there's been this slow and steady creep of this corporatization of public health. Would that be a fair assessment, or has this been a relatively rapid onset?
No, it's been a slow and steady creep, I think. And, people can speculate what the drivers are, but, we're all human. We all have underlying drives of greed and so on. If you're looking at, and, we live in societies where companies have an obligation to make maximum return for their shareholders, for their investors. If you put aside, ethics and morals and all that stuff, and you look from a purely business point of view, and you're running pharma, then this is what you would do. You would convince people that you convince people that there's a big problem. You convince people that the way out of it is pharmaceutical, and then you would use something like a vaccine, where, especially one where you have to keep having more and more vaccination, because then you're sort of printing money, which is what we've seen. And that's not a reflection on the vaccine either way. It's just the reality that they have proved they're extremely good way of making money, irrespective of their impact on health. So if you can hook a society on recurrent vaccination for as many diseases as possible, then you can really concentrate wealth within your company. And, we've seen, I think, historically an unprecedented concentration of wealth in the last 2 years. But that's, again, a continuation of what's been happening in Western society over a few decades, where, the people in the highest incomes have slowly accumulated a higher proportion of total wealth. That has accelerated in the last 2 years. And, we'll get to the Pandemic Treaty proposal later, but I think that will lock in the ability to keep doing that. A weird thing in this to me throughout has been the politics of all this. That would tell you that normally, I think left and right are sort of redundant in politics, and we didn't go into this too much, but, what I've been saying is orthodox public health, and, the idea of horizontal approaches, community-based care, et cetera, was always a sort of left-wing approach to healthcare. Now we are finding, or the people who are espousing that, a lot of them are now on the side of really pushing this pharma-based approach to everything, of locking people down, of taking away their income, of doing things which we know, especially in low-income countries, are extraordinarily harmful to overall health and to mortality.
Yes, I think that you're right in pointing out that those countries are particularly going to suffer, but it doesn't take away the suffering in developed and wealthy countries.
It doesn't. No, I think low-income countries, it's etc. It's amplified.
Yes.
But, and we know with these, in any country, if you reduce GDP, there tends to be a shortening of life expectancy over the next generation or so. Yeah, and that's partly because, in general, the wealthier you are, the longer you live, and that's shown in sort of the Whitehall studies and so on, which is to do with a whole lot of factors, but even irrespective of sort of smoking, alcohol, and these things which we know are harmful, obesity and so on, there's still, if you're wealthier and you have more control over your own future, you tend to live longer. That's known in wealthy countries. It's even more so in low-income countries, where drops in GDP have a dramatic impact on maternal and child health and so on just the availability of commodities in much shakier supply lines than we have. if you have no malaria medicines, lots of kids will die of malaria. It's not complicated. You block the supply lines or you stop kids with fever going to a clinic, they'll die of malaria in malaria endemic countries. And the way to stop them dying is to get them seen early and have the right diagnostics and medicine available. So, so we know that harming these economies, reducing the family income, etc., will do this. Yeah, I don't know. It's just, I mean, this is going back, this is what alarmed me early on. It became so obvious by March 2020 that we were going to kill far more people, especially in low-income countries, but also in high-income countries, from the response than from COVID. And those numbers haven't changed. And even the World Bank and UNICEF and so on have data out reflecting this. But we don't see it in the main media.
No, and we don't, you know, you've referenced the global health community, and whether you're referencing organizations or individuals within that, I think there's been a very limited critique or even reference to the types of horizontal community-based approaches that you've discussed. I think there's been a limit, whether it comes down to a lack of awareness of the kind of trends in health governance, or ignorance, or failing to put their head up against the tide. What do you think has driven or allowed the kind of global health community to?
It's not a lack of awareness. The people might have heard of the Alma Ata Declaration from the late 70s, which was a large meeting in the Soviet Union, as it was then, where sort of the globe, they sort of put down in writing this whole community-based approach to public health, community health. And there was a meeting WHO ran in 2018 in Astana, which reiterated that, and WHO put out a declaration from Astana, etc., reiterating Alma Ata. Every public health school emphasizes, or as far as I understand in my teaching on, the importance of social capital in life expectancy, the fact that most improvement in life expectancy was lifestyle and living conditions, not in pharma. So this is standard public health practice, and there's most global health people in WHO, Global Fund, UNICEF, whatever, were completely on board in 2019 with this. In 2020, suddenly they're apparently not. So why is it? I think there's a number of reasons. There is a new, along with the funding of WHO, Gavi, CEPI, etc., there's been a big funding of global health schools in the Western world. So literally hundreds of millions of dollars spread over years has been put into training young global health people, most of them fairly wealthy people from Western countries, who are then sent out by these organizations who are funding the schools to implement the organization's work, or they join WHO, etc., and implement the organization's work through WHO. So we have had a lot more people who are being, particularly from Western countries, from rich backgrounds, who are doing this. And they are very dependent, as are everyone in these organizations now, on a relatively few funding sources. So, so this concentration of funding is important, I think. So if you're in WHO and you've been there a few years, your salary is dependent on funding from a certain source, and it's back to this directed funding issue. Your salary is dependent on essentially a person liking what you're doing outside of the organization, or an organization outside that's doing the funding. And if you stand up and say what they're saying is wrong, it's not an unreasonable prospect that you won't have a job in the foreseeable future, which means you lose your salary, you lose your kids' education, which is subsidized. You lose your pension, a large part of your pension often. Healthcare for your family, you may have to leave Switzerland or wherever you are because you're not a resident there. So you can, people in these organizations become very dependent on their funding sources and on pleasing their funding sources. So it takes a lot of courage and the ability to lose your salary in order to stand up and say and speak against something you see as wrong if you think it's wrong. So I think people know the basics of public health. They know the basics of what kills people. They know that COVID is mostly killing people over 75 years of age, certainly in countries where we measure it. They know that children are at minimal risk. They know now, if they can read at all, that post-infection immunity is more effective than vaccine-induced immunity. And that's very clear now, and even, major funders admit that. It's clear that it's long-lasting. So it's clear that, and it's clear that almost everyone now is immune with the Omicron variant. Pre-Omicron, most people in sub-Saharan Africa appear to have had immunity. There's a paper came out recently showing, I think 65% were seropositive on average across the continent in about September, October 2021. So that's pre-Omicron. Then the Omicron variant comes out, which is as infectious as measles, spreads everywhere. Almost everyone on Earth has probably had it by now, and China's just getting it. We know that imparts good immunity, so we know that almost everyone is immune. So they know these basics. They know that there are lockdowns were doing a lot of harm outside of COVID. They know that the vaccine won't add much in mass vaccination of people who are already immune and who are at minimal risk in the first place, which, in sub-Saharan Africa, it's 50% of the population are under 19 years of age, so in Western terms, children. So they know all these facts. These, you can't hide from them. I think, why people go along with it, I think it's difficult to stand up in a large hierarchical organization. It's difficult to go against your funding. I think a lot of people are just waiting for someone else to stand up and take the flak so that they can just join it when it's more popular. I think some people are genuinely fearful. I think despite sort of knowing these facts, some people, and I know people who are genuinely fearful of catching the virus and dying, even though their risk you can show on paper is about the same as their risk of walking across the road in the next year and being hit by a car, which is not zero either. Being hit with these numbers in the New York Times every day has an effect on people's psyche. And I think a lot of people really, they're on one level, they can believe that they can see the data, but on the other level, they can't bring themselves to sort of, act on it. They're more driven by personal fear or by fear of just being on the wrong side of the group their peers are in.
I mean, David, you outlined some what I would deem to be concerning or very concerning trends within global health. If it continues on this trajectory, and perhaps this will lead us to talk about the Pandemic Preparedness Treaty and how this connects with some of the trends, but some of these trends, the corporatisation, the influences you've described, but also the influences on the people working within these institutions is profound in the way you've described it. What do you think the future looks like? What trajectory is global public health heading now, and what disturbs you most about that?
I worked in an organisation once where there was a culture of not telling the truth, of exaggerating in public meetings, etc., of making stuff up, when people visited and so on. Early on in that, in my time there, people come to me and say, David, you've got to try to address this. This is bad, etc., etc. After a few years, a lot of these people were doing it themselves because they realised that there's no sanctions on doing that. It's actually good for Korea. I think this is the same. I think if this goes on too long, it'll just become normal and I think it is becoming normal, to not worry about killing lots of people anymore. And it's just the job. And people will lose, they'll force themselves almost to lose their idealism and their care and compassion, and they will just accept this as a routine office job, which a lot do anyway. And that obviously is a disaster for the people at the receiving end, because there's a lot of people in the world who don't have the resources personally to really give themselves a good life expectancy without some help from these organizations. I think that it's a global health industry now, I think, and I think the danger is that it's just going to lose its way completely and just become an arm of profit making for large pharmaceutical companies. Where does that go? I think, we need to fairly urgently, I think, completely revisit the whole, what are we trying to do in public health, the whole basics of human rights, conflict of interest, etc. I don't know. I don't see how that can happen at the moment from within those organizations, because the organizations are so caught up in the way that funding is given. And, the funders are so caught up in having to maximize profits for their shareholders. So I think we're in a sort of cycle that we've got ourselves into by ignoring conflict of interest because money seemed important to help people. We've got into a cycle where it's hard to see a way out that these organizations can take without almost, massively downsizing and self-destructing themselves. And I don't think that's going to happen. I think the way out, really, the only way I can see is for the countries at the receiving end of this who are becoming poorer and the populations who are becoming poorer have got to start saying, go away, you're not helping us, and start setting up their own internal organizations and ways of doing things. I think we're seeing a sort of colonialism, really. And the way to get rid of colonialism is to achieve independence. So I think the countries at the receiving end, we're ignoring it's the same with the Western public in a way. That's what democracy is supposed to do. We've got to take back democracy, perhaps. But in low and middle income countries, I think the populations in the end have got to see that their interests aren't necessarily being served by concentrating their wealth in the hands of a few people in rich countries, and that they would be much better off retaining the funding and the control of their own destinies within their own hands. If you look at vaccine uptake in Africa, for instance, it's quite low. And I think it's not because poor supply lines, it's not because people haven't heard of the vaccine. It appears to be because people are becoming very suspicious of what's going on. And, they're aware that immunity, we should be, that immunity is protective. They're aware that mostly very old people, and in sub-Saharan Africa, less than 1% of people are over 75. Over 75 is where most people die from COVID in rich countries. So less than 1% are highly vulnerable in terms of age. half are children, and a very, very low vulnerability. But they have these huge other problems that are getting worse. Malaria is getting worse in Africa. There's an extra 65 million people, 65,000 people, mostly children, died of malaria in 2020 compared to 2019, according to WHO. So that's mostly, and WHO acknowledges, mostly due to lockdowns. A child dying at 3 years old from malaria loses 70 years of life. 80-year-old with renal failure dying of COVID probably loses 2 or 3 months. So when you look at disease burdens like this, it's pretty stark what's happening. And I think people are aware of it, becoming aware in these countries. So I think perhaps in Asia it's a little bit different, especially Southeast Asia countries tend to be more authoritarian and control information better. But I think to me, in a way, sub-Saharan Africa is a bit of a hope for the world, because I think people, the way communication works and the way people manage themselves is going to be harder to impose this system on them.
I mean, if you just take the global spending on the vaccination program, and if you look at those countries and areas you've outlined, you would surely see that it's a disproportionate. I've seen some reports, but the volume of spending on simply COVID vaccination programs versus malaria, tuberculosis, HIV, it just seems like a gross misallocation of resources in terms of overall risk.
Yeah, we spend globally about $3.5 billion on malaria, roughly, including from the Global Fund, from various aid organizations, plus within countries. The Africa CDC estimates just to vaccinate sub-Saharan Africa with about 70-80% vaccination for COVID will take $10 billion. So 3 years of malaria spending globally. There was some modeling from Yale on COVID vaccination costs recently showing, for all low middle income countries, so not high income countries. And that estimate about $35 billion for 2 doses, which we know won't stop transmission at all and will wear off over several months. And $60 billion if you give 1 booster. And, then you're giving some protection against dying for the very few people who don't already have immunity, which is probably a fraction of 1%, who are at high risk and aren't immune now. So you're spending this, $35 to $60 billion for temporary protection for these people. And malaria, which certainly in terms of life years lost is worse in these countries than COVID, you're spending 1/10 of that. It's just stupid. I mean, it's not complicated, these numbers. They're talking about the Pandemic Preparedness Treaty spending $10 billion a year. I saw one thing, $55 billion. I mean, we'll see, but the Global Fund itself for TB, malaria, and HIV, that's the biggest funder. That spends about $3 to $4 billion a year on those 3 diseases. There's other sources as well, but that's the spend on those 3 diseases: malaria, tuberculosis, and HIV. We're talking about spending far more than that on pandemic preparedness. We've had WHO lists in the last 120 years for pandemics before COVID. The first one was the Spanish flu in 1919 to 20, when it's generally agreed a large part or most of the mortality was due to secondary bacterial infections. We didn't have antibiotics. And people die, bacterial infections when they get flu, a secondary infection. You can give antibiotics, it stops it. So we wouldn't expect to see that mortality now at all. After that, there was the Asian flu in 57, 58, killed about 1.1 million, which is not that much more, 2-3 times a normal flu year. the Hong Kong flu in 68, 69, when Woodstock went ahead, people lived normally through these. 1 million people died. And then the last one is swine flu, which was just 120,000 to 200,000. So a third of what those that die every year from malaria. This is in 120 years. So pandemics are a rare thing. And even when they occur, leaving aside COVID, and mortality is hard to assess in COVID, but the others, they don't kill. Even when they come, most of them haven't killed as many people as die every year from tuberculosis or every year from HIV. So, and they come once a generation. There's no reason why pandemics are going to become more common. There's a fallacy really that we are mixing more with wildlife and therefore we'll have more pandemics. It's silly. There's less and less wildlife in the world. There's less and less natural habitat. The COVID lockdowns will have massively reduced it further because conservation efforts and so on have stopped. So people have always lived with wildlife. They live far less with wildlife now. They mostly live now in urban settings. So we're not contacting wildlife more. We're probably contacting it less. So we're not. It's silly to say we expect more pandemics. We have antibiotics now. People say 5 million people, 6 million people have died of COVID, but most of them, in the US, 95% had severe morbidities, which would probably have killed them within a year or two. And often before that, if you look at the nursing home deaths, I think in the UK, the average life expectancy in a nursing home is about 6 months. Because most people go into a nursing home soon before they die. It's 30 or 40% or something of UK deaths were in nursing homes. So most of those people, were going to die within 6 months to a year. It's not diminishing. When someone dies, it's tragic. Everyone dies. It's even worse if they die shut away from family and, alone, which we've done, which is just, it's another story, but it's just totally lacking compassion and decency. But, the mortality even from COVID in terms of life years lost is very low. And, we did some modeling, which is published in the American Journal of Tropical Hygiene a year ago on comparing, sub-Saharan African countries, the burden of COVID to the burden of malaria, TB, and HIV. And, we always talk about disease in the past in terms of burden, which is life years lost. So disability adjusted life years or dailies, or we use qualities. But it takes into account, if an 85-year-old dies, it's tragic, but not as tragic in terms of life years lost as a 3-year-old dying, which I think 99% of people in the population agree with in general. If you do that for COVID, because most people who die of COVID die actually in Western countries at about 80 or more, you have very few life years lost compared to cancers, compared to all these other diseases. In Africa, compared to malaria, HIV, TB, COVID is less than, in terms of life years lost, is less than 5%, I think, or 6% of each of those diseases individually. So it's a tiny problem in those normal burden terms. People have stopped using those terms in the last 2 years, which is really interesting. So the modeling groups like IHME and Oxford and so on, they're not putting COVID out in disability adjusted life years lost. Because if they do that, it looks tiny. And I sort of know that because I talked to a couple trying to get some help to do modeling early in the pandemic. And one of them admitted that he'd done the back of the envelope calculations and he couldn't work with me because COVID wasn't going to be a thing if you did that. And that would look bad within his organization because, their funding streams. So we've sort of done away with the normal metrics for assessing disease because COVID kills old people. So we've suddenly made old people's deaths at the end of their expected lives exactly the same as a child dying from malaria, or more so. So sorry, I've rambled a bit, except to make the point that these numbers are really stark, and yet we're talking of spending tens of billions of dollars on trying to stop almost none now of these people from dying because they're nearly all immune. And CDC have shown and published that if you vaccinate an immune person, it makes almost no difference. They're already immune. You don't add, you add so little, if any, that in the whole scheme of things, you can't see it on a graph. Mm-hmm. So, it's, in the end, it's a nonsense. Vaccinating non-vulnerable people who are already immune, it's at this sort of cost. And every time you put money into this, you take money from something else because we have a bucket of money. Every time you divert health workers to go and vaccinate these people who are at no risk from this disease, you are taking them away from seeing kids with fever, from seeing mothers who are having a complicated pregnancy, etc. So there's also a huge opportunity cost. And everyone in global health knows this as well.
I mean, there's three things I've kind of extracted from this. Is one, the prevalence of pandemics is minimal, and there's no reason to expect that to sizably shift. Secondly, we've seen this verticalization and corporatization of the public health. And then thirdly, we've seen this kind of misallocation of resources. And my concern in the context of the Pandemic Preparedness Treaty is it essentially it bakes in all three of those problems, but not only that, it worsens that. So the idea of reversing this kind of colonialism is that you put the hands back in the power of the community, the power back in the hands of the community to make the best possible public health decisions for their territories, for their people. The Pandemic Preparedness Treaty essentially reverses that in principle.
Yes, and it does. It reverses the basics of global health that up to 2019 were underlying almost every key strategy of WHO. And I'll just have one caveat on, we won't see more pandemics or more frequent. I think we will see far more frequently declared pandemics. And the reason for that is we're building a whole industry. And, with this new, now they're touting yet another agency. We already have CEPI just for pandemics. They're touting yet another agency that is somehow going to go and put fires out at a drop of a hat, etc., of 2,000 to 3,000 people to support this proposed pandemic treaty. If you have thousands, and we're talking thousands now, of people who are concentrated on pandemics, and the Global Fund is also getting onto the pandemic bandwagon, etc., then when you have, we will soon have perhaps 10,000 people just funded to manage pandemics. You will have more pandemics because, and the definition of pandemic is very woolly. It's essentially anything that the WHO declares as a pandemic. So you will start to have more and more surveillance. Viruses will pop up. Oh, this could be a pandemic. We will lock down 10 countries, stop all air travel, impoverish a whole heap of people, and vaccinate lots of people just in case. And so we may have a pandemic every 2 or 3 years, every time a slightly different variant of flu comes out. But this is the problem, if you create an industry like this, then you will create, they need a reason for existence. It's untenable to have tens of thousands of people sitting around for the next 20, 25 years waiting for when the next pandemic is actually due. Remembering the last one was 1969, so that's 50 years ago, or leaving out the tiny one, which was swine flu. So you can't have people sitting around like that, so that they'll have to create work for themselves. It's just human. And, It's just what's going to happen. So then we'll end up spending more money on this. We'll end up concentrating more resources on this problem versus the things that really kill people. These other infectious diseases are endemic. The malnutrition, which is growing across much of the low-income countries. Indoor air pollution or sickle cell disease or whatever. There's a lot of stuff out there which kills more people on a year-by-year basis than the odd pandemic. So we will neglect all that increasingly, and we'll concentrate more and more on this because people are paid to do this. If they don't do it, they'll lose their jobs. And there is a huge profit incentive, which there isn't for these other problems. And profit is an inevitable driver of, this is commerce, isn't it?
I think the other variable there is the increase in surveillance that we've seen, health surveillance.
Yeah.
Just unprecedented scale of testing, different modes of viral data collection, sequencing, genomics. It's just been on a profound scale greater than we've ever seen before. And if you apply that to every circulating virus, then it's going to produce a similar result. I mean, you
can do it for rhinovirus. We all have colds from rhinovirus every couple of years, and you can have a pandemic of rhinovirus, and it will kill some people people will die with it because people die, and if you keep testing, some of them will have a cold when they die. And viral diseases are the way that a large part of the population actually does die because it's what takes you away when you are almost gone. So if you have, Alzheimer's disease and renal failure and stage 4 cancer or something, and you get what to you or me is a fairly routine viral illness, that may well tip you over. And if that doesn't, something else will in the next few weeks. But you'll end up with people dying. If the New York Times can publish completely out of context, this many people died of rhinovirus today, then people will get scared and see it as a pandemic. So,
I mean, it already seems to be happening. Although it's to caveat this point, I think the lockdowns have seen this sudden. We're seeing the offshoots of these new surges in what would be normal circulating illnesses. We're just seeing, in the wake of lockdowns and policies in the last couple of years, just these, rise in immune-related health problems, which is unsurprising given what we've seen. But again, the headlines that come with them, every one of them is a crisis. It's RSV or any other particular seasonal virus that's coming up. We're seeing just dramatic headlines. It's become normalized. It's becoming normalized to surveil for all of these things. And it's really worrying. And I think this Pandemic Preparedness Treaty, the track is that the proposal will be created over the next 12 months, and it's due to be approved in 2024. And they're expecting every country on Earth to sign up to this treaty, which essentially centralizes the approach to pandemics. The idea of got this one-size-fits-all approach. To me, it just really exacerbates all of the problems that you've outlined. But I wonder if it needs to go through its failure cycle in order to break it, or whether there's things we can do to take an alternative approach.
I hope not, because I think so much damage will be done in the process that it will take it will already take generations to get over the lockdowns and so on. UNICEF, I think, estimates, this is an example, 10 million extra child brides in the next 5 years or so. This is, that, and, we 120, 130 million additional people in severe food insecurity, et cetera. These have knock-ons for generations in terms of health, in terms of freedom, etc. In terms of the other aspects of health, which is not just physical, as WHO says, it's mental and societal health. Diversion of resources like this is going to be exactly the same. It's a massive hit on the economies of low-income countries. It's a massive hit on high-income countries' economies. This is all taxpayers' money that we're talking about to fund these people who are going to either sit around for 20 years waiting for the next pandemic, or declare pandemics so that they can do something. So yeah, I think it's extremely harmful. I think we have to try to stop it. Pandemic preparedness is important. In terms of disease burden, it's even more important to address childhood malnutrition, to address lack of zinc and vitamin D, and to address obesity in high-income countries. So if we have if we're going to have problems from viral pandemics in high-income countries, it's probably due to obesity. It's due to underlying poor metabolic states of a very large part of the population, more now than 2 years ago. And it's very clear with COVID, people, fit, healthy people, even old, fit, healthy people, get over it almost always. But people who are obese, who have chronic renal failure, etc., who have diabetes, which is due to diet generally, etc., they're the ones who are dying. So COVID has been just as much a disease of obesity and metabolism as a viral disease. And you can see that internationally, where mortality in Japan is very low, where obesity is rare, people exercise, etc., into old age. It's a lot more common in North America. It's even more common in South America. You can see it in South Africa, where obesity is more of an issue, and people older, but has a much higher mortality than the countries north of it. So if we want to prepare for pandemics, the answer is not to have thousands of people sitting around pouring money into new vaccines, etc. It's addressing fitness to withstand viral infections of the general population. And just like going back to lifestyle is the biggest improvement on mortality, this is probably the way that you're most going to mitigate future pandemics, is by helping the population to be resistant to them, to normal viral diseases, by strengthening immunity. I think it's extremely confusing why this wasn't a big issue in COVID. Why weren't people in nursing homes all being given, vitamin D and zinc and stuff, which isn't just something that's come up in the sort of weird offbeat media in the last 2 years. These are basic, it's basic in health. We know that these improve immune competence. We know that healthy diet improves immune competence. We know that lack of stress does. This isn't new. It's well known. It's standard orthodox public health. All this was abandoned in favor of a vaccine. I think there's reasonable arguments, we don't know, but that if we had concentrated on them rather than the vaccine, we may have well saved far more people. There's certainly a lot of credible physicians out there who are pointing that out.
Mm-hmm. So we've outlined some of the concerns around public health and global health in general, as well as some of the specific issues to the Pandemic Preparedness Treaty. What do you think can be done to tackle this trajectory? Do you think the Pandemic Preparedness Treaty can be countered? What's a more ideal outcome that could be pursued?
So yeah, it can be. There's a few ways. The people who work in global health, in WHO and so on, can go back to the basics of public health and look at disease burden and look at what they're doing, and they could say, no, this doesn't make sense, and this is why. I'm not confident that will happen, but there are, people in UNICEF have put out very good data on the harms that have been done. So by the lockdown, so there are people in these organizations who are trying to do the right thing. That is one way. But a treaty has to be, in general, ratified by parliaments, etc. Countries have to agree to it. The WHO is the sum of its parts, which are, in theory, the countries that belong to it. They meet at the World Health Assembly every year. If those countries, if those governments say, this makes no sense, because this is taxpayer money in the end. If this makes no sense, our taxpayers have made it clear that they don't want to concentrate their dwindling wealth within the hands of large corporations in order to mitigate something which historically and rationally is a very low risk, when they have much more pressing concerns, then it won't happen. So I think the way it is going to stop is if people in countries make it absolutely clear to their governments that it can't go forward. To do that, people need to understand what is happening. They need to understand the basics around disease burden. They need to educate themselves quickly, because it's their taxes, which we're talking about, and it's their future poverty, which we might be locking in. So they need to educate themselves around these burdens. They need to talk to their local representatives who sit in their parliaments. And we need to have people in parliaments questioning, asking these basic questions about disease burden, about allocation of resources, about where is the evidence that $1 spent on this is going to improve global health more than $1 spent on obesity or malaria or cancer. And so we're hopeful that that'll happen. So there are a number of organizations trying to do something. Panda is trying to develop a campaign, for instance, to help people to actually write to MPs and point out the key issues that this involves, so that they can ask questions. And we don't need to go into what is driving this, and is it just corporate greed, is it left-wing, right-wing capitalism, whatever. In the end, this needs to fall over just on the numbers. The numbers don't add up. It doesn't make rational sense. We need to stop panicking and stop believing everything we hear and just sit down and think rationally. And I think if we do that, then this treaty won't go ahead. So it's a matter of getting enough people to do that.
Do you think there's a risk? I think within the political, there's a lot been spoken about the failings of individual governments and countries in the response to the pandemic. And it doesn't matter which side of the coin you're kind of referring to, whether, those that are saying we should have locked down harder, faster, longer, versus those who are saying we should have avoided them at all in the first place. Either way, there's this pointing towards government incompetence. Do you think there's a risk that governments will see, nation states will see this as an opportunity to really outsource and delegate that responsibility to a central authority, so that in the future they mitigate that, fall in public opinion? Because if the WHO creates this centralized approach to pandemic management and it creates profoundly disastrous effects, well, the government can point their hands straight back at the WHO and say it's at the. Is there a possibility that governments will see this as a get out of jail free card?
They could, and I think there's pressure on them there's pressure on them to respond in some way, because doing nothing is dangerous. And if they can say, well, we had to do it because we're in this treaty, but I mean, this is a constant drain on budgets that we're talking about year on year. It's a huge diversion of resources. They will have to answer to having worse health systems in their own countries as a result of diverting resources to this. They'll have to account for lower pension, lower social welfare, less infrastructure spending, because they're spending more money on this. So, even with that, there are costs which they will have to account for just in funding this every year.
Yes.
So, and in the end, these governments are supposed to be responsible to taxpayers. There is another issue here. I mean, for years we've had our elected representatives going off to Davos, and I've always been uncomfortable with that for a decade or two. That why are they making deals with very wealthy people whose main attribute is being very wealthy, when they are supposed to be directly representing us and transparent with us? So I think there's a problem there. I think that there are conflicts of interest within government. There are lobbies, etc. And they are also responding to them because it's easier to do so rather than stand against them. And it can be risky for a politician to stand up against powerful lobby groups. So, yeah, there are all these factors which work in favour of them signing this treaty. I think in the end, they have to be scared enough of their taxpayers that this is unacceptable from a resource point of view, from a sovereignty point of view, etc. That, a bit like Brexit in the UK where you are, in the end, the wealthier parts of society and the politicians in general and were in favour of staying within the EU, but in the end, the taxpayers, rightly or wrongly, said they want their own sovereignty, their own independence. I think to a large extent, this is a very similar issue.
Yeah, I think that's a very important point. I think the other piece I take away from this is that, we've talked about some of the problems of the pandemic response in itself, yet it feels like this treaty is being prepared before there's been any kind of post-mortem analysis of the response itself.
Oh, yeah. I think it has to be, because I think a rational post-mortem will be so damning that they won't be able to have a treaty that suggests repeating this.
Yes. Well, I think that would be very clear. But I think what that points to, for me at least, is that there is a couple of clear routes of action which will fall in the public hands. One is firstly that transparent public inquiry process to draw out those clear learnings on a national and international global base, on a global basis, because I think the lessons need to be drawn. Unfortunately, the public inquiry process that we're witnessing in the UK at the minute, at least, is likely to take an angle that fails to deduce the actual learnings that need to be learned. There's very much the emphasis is on the bereaved of COVID versus the harms caused more widely. So I think there needs to be a truly independent inquiry that is not run by governments or representatives of governments. And then secondly, this piece around, yes, the accountability for the pandemic management, but this treaty that's been proposed, I think it's going to require a huge global effort to actually overturn this. I think one piece of hope I take from the discussion that you've shared today, actually, with the countries in the developing world, is that they perhaps offer a glimmer of hope in the sense that they feel mistreated by these bodies, and there's a sense that they are more likely to retract from the treaty, and in which case I think there's a requirement that a certain percentage of countries sign. So I think perhaps there's potentially a greater opportunity in those countries where they feel mistreated by these groups, where there's
I think so, although what the population thinks and what the leadership sign is not always the same thing, but I think you're right.
Yes, and it may be more of a generalization. It may not be appropriate for me to say, but I think, in some of those developing countries, you've got less of a democratic governance. Not in every case, of course, but I think the will of the governments in some of those nations is probably stronger than the will of the people.
Yeah, and it varies as well. I mean, yes, I think leaders in any country can be bought. Western countries, low-income countries, it doesn't make any difference. I think, I don't know whether we can generalize that, but I think it's clear in a lot of countries that leadership does not necessarily reflect what the people think. And that's what concerns me about the whole Davos agenda and so on that we've been witnessing for a couple of decades, that there seems to be an increasing corporate influence over government versus grassroots democracy control.
Yes.
We spent hundreds of years to build, but can be lost very quickly.
Yes, I mean, civil participation in the UK is its lowest level in history in terms of party membership. So on one hand, there's a huge imbalance now. You've got the corporate interest over government, and then you've got this minimal influence of the public over government. It's the structural imbalances are enabling things like this to happen. But you have to look at cause and effect, and where this began and where it's landed today. But either way, it points to today the people have to do something about it. Because I don't think there's going to be a savior in the
there's no white knight riding on the horizon here. It's people are going to have to fix it themselves, I think.
Yeah. So I think the work that Panda are doing on this is vitally important, and I've shared the link here. Panda, it's just the Panda website, pandata.org. /WHO paradox. You can see the action that's been taken by Panda there. There's a downloadable template that you can access if you wish to use that to write to your elected representative. But I think this is just the beginning. There's lots of organizations now paying attention to this. There's the perception that we have a time scale to tackle this particular issue. But as you've outlined, David, I think there's a risk that there's a new COVID variant or another perceived threat that accelerates the timeline of this type of activity. So I think we can't rest on our laurels with this particular treaty. I think it requires urgent attention. But I suppose my broader worry, David, is actually some of the issues we've talked about here. These underlying trajectories aren't limited to the pandemic treaty. It feels like there's almost a systemic reform of public health that's required to avoid these happening more broadly in the future.
Of society, I think, it's not anew that people worry about concentration of wealth more and more in a fewer hands. That's been going on for 2-3 decades. It's accelerating. People have glibly said that can't be a good thing. It's going to all end up in a mess. It is going to end up in a mess. It always does, doesn't it, in history? So, I think this whole thing is a symptom of this underlying problem we have in, as you said, disengagement from governments, but also increasing concentration of wealth and power among a relatively few individuals. And it doesn't mean those individuals are good or bad. It's just whenever that happens, inevitably, things turn out badly, because even though having everyone have a say is a flawed system, in the end, if we're all equal, you can't get away from the fact that that's going to it's better in the long run for society. I haven't put that very well, but this is but basically, if we believe in the basis of democracy and human freedom, and we believe that all people are equal, then we can't have a small group of very rich people telling everyone else what to do. And it's been tried lots of times in history, and it turns out badly, and it's obviously going to turn out badly again. They're not smarter than the average person. They're just perhaps more ruthless, and they happen to have much more money.
I think what's interesting is I read a study on this recently that examined quote unquote financially successful people who have achieved the highest accolades in one particular area. There may be some transferable skills, but actually the success rate once one individual goes into another industry is typically far lower than the industry in which they've succeeded. So when you've seen entrepreneurs who have made billions in the computing industry suddenly going to other industries, there's certainly no guarantee of success. In fact, there's an increasingly lower proportion of success. But that, even taking that aside, I think your point is absolutely key, is that the world is increasingly, the decisions in an increasingly global world are being made by an increasingly small number of people, and that cannot end well, and it is down to us to change it. I suppose I'd like to conclude, David. We always ask our guests that this is the Elevate podcast. We kind of want an inspiring message for the future. Our goal is to elevate humanity and enrich the world. What are some words of hope or positivity that you could share that leave people recognizing that there is a chance we can change this?
I think that most of us still do live in some sort of democratic system that the people who are running all this mess, I think it is, are not smarter than us. They're just in positions where they can do that. I think society in the past has got out of holes like this. I think it's quite possible to do it again. I hope it happens sooner rather than later. It will eventually happen because these things go in cycles. But I think it's hard to be really positive, because I really think we're looking at tens of millions, perhaps hundreds of millions of people dying unnecessarily because of what we're doing now and over the next few years planning to do. But I think it is possible for us. People do have the power if they get together. People, politicians will listen if enough people make it really clear.
Thank you, David. I think
it's hard to be incredibly positive, right?
Yes, I also think it
I have got great words of wisdom there, except that there's no excuse for not trying, and there's no excuse for just complying with what is completely wrong.
Thank you, David. I think that pragmatism is vital right now, actually, to have that balanced approach of recognizing the problem and the magnitude of the solution. There is the idea that there's going to be an overnight success story here is, again, a fallacy. So I think it's really important. This is something that there's a counterculture movement effectively required to tackle these underlying issues.
Yeah.
And that's why we launched Elevate, is really to play our part in creating those counterculture shifts that will create a new trajectory, and from a small wave start to build something much bigger. And I know Panda and other organizations are the same. So
and I think on a positive note, there are like Elevate and the alternative media that is arising, and the lack of trust in our institutions, I think, unfortunately, is a good thing, because I think it signals that people are waking up to the fact that something is wrong. So without that, it's not going to get better. So I think that lack of trust is a good thing, because people need to question, and you're not going to rebuild these and make them better until people really recognize that something is badly wrong.
Indeed. Thank you, David. I would like to thank you for your time with us today. It's been a fascinating conversation. I really appreciated some of the clarity around some of the developing nations that we've not yet discussed here on the podcast. I think that provides some new context to the conversation. But ultimately, we've witnessed really there's some really systemic issues that need attention. So what I'd like to do is invite our audience, if you're interested in being part of these types of conversations and playing your part in trying to alter the trajectory and tackle some of the issues we've talked about today, I invite you to join our Elevate network. It's a private community a private change-making community where we're seeking to tackle some of the issues that we've raised today. In particular, we're going to start focusing on the Pandemic Preparedness Treaty and supporting other organizations that are tackling this issue as well. But more broadly, we're looking at systemic and societal change and how we can actually look with an open mind and heart at the systems and structures that are currently guiding humanity, and starting to evaluate how we can create change in those in the key areas that affect all of our lives. So, You can join us at www.weareelevate.org, join our private community. And we invite you also to join our podcast mailing list at danastingregory.com/podcast, where you'll get to hear about the latest podcast interviews like this one, as well as all of our campaigns and initiatives that we're following. So I'd like to say thank you again to our guest today, David Bell, and thank you to each of our audience who have tuned in. Please do share this episode. It's a vital conversation, and we do need to get these issues into the minds of the many in order that we can affect change moving forward.
Thanks, Dan. It's a pleasure to speak with you.
Thank you.